Thank you, Dr. Sanjay. And I think shifting gears slightly from the surgical mode to the biomechanical mode of what's the effect of refractive surgeries, laser refractive surgeries on the corneas, and no financial interests in the mention of any products during the course of my talk here. So we looked at how corneal biomechanics changes when we take up laser refractive surgery. So we did a study looking at the myopic femtoflap LASIK and related it to the amount of the percentage tissue altered here in routine LASIK patients here, and based on the type of on the amount of PTA, when the PTA was less than 27%, less than 33%, and less than 40%, which is all within the safe or described ranges of the PTA. And we looked at how this, of course, was done with the Ora machine way back. We didn't have the corpus was just coming in then. And we looked at how the corneal hysteresis and the corneal resistant factor changes when we are still doing it within the safe range of the PTA. And the correlations did reveal that when your ablations are on the higher side, when the PTA is on the higher side, that does produce a significant change with a mild negative correlation here. What we are looking at, or what now is evolving in our understanding in corneal biomechanics and imaging the corneal collagen, is now said to be more precise and more revealing with the Brillion microscopy here, which looks at the organization of the collagen fibrils here. I think I wouldn't go into the physics part of how Brillion microscopy, the scattering really works in this here, but just to make our understanding more simple, this is how you get high resolution macroimages of the collagen fibers using Brillion microscopy. And as you can make out here, the anterior fibers stop short at the periphery, and the posterior collagen fibrils do continue into the sclera, and that's how the normal structure of the collagen layering exists in the human cornea here. So what happens here is when we do alter this normal structure by laser ablations, either by cutting or by a lenticule removal, we are still causing a biomechanically weakening effect in the anterior part of the cornea here. And these fibers, which are stopping short at the periphery, now become mechanically inert, and the load which was borne by these fibers is transferred onto the posterior collagen fibrils here. So this is the biomechanical change which is happening, and I guess still we are yet to look at a machine which will be effectively be able to pick up this biomechanical change induced effects on the cornea following all types of laser refractive surgeries which we are performing here. What we currently have with us is the dynamic imaging of the cornea here, and this perhaps is the only machine which is now helping us or increase our understanding of what is the biomechanical effect of laser refractive surgery. So largely the earlier pre-screening modalities helped us to describe or differentiate a normal cornea from a biomechanically weak cornea, which is a keratoconic cornea. Most of us do pick it up because it's quite obvious. The difficulty arises when you will have to pick up the formae frustae or the subclinical keratoconus cases when you're taking these up for refractive surgery screening. And as we all know that more and more patients are now opting for refractive surgeries here. So the onus lies on the surgeon in being able to pick up those subtle abnormal corneas here and pre-treat them with the available newer modalities, which are probably you would want to prep them by a collagen cross-linking, or you would like to do other contour related laser refractive surgeries before you embark on refractive correction for these patients here. I won't go on into all these research aspects of the various the waves which are described by the dynamic corneal imaging here, which largely I think is of particular importance when you're looking into research here. But Corvus does help in giving us a biomechanically corrected IOP here. It helps us to assess the collagen cross-linking and gives a better predicted outcome of our refractive procedure which we are adopting to, helps in formae frustae and subclinical keratoconus reduction and applications in glaucoma management as well. There are multiple parameters here. There are about 14 to 16 parameters which one takes into analyze if you're looking at the research mode of application of this device here, and won't trouble you with a lot of those data, but something which in particular is the integrated radius, the ambrosio relational thickness, the stiffness parameters, and these are, and the applanation time. So these are particularly important ones which we need to look at and which we compare when we are looking at those corneas which are going to be susceptible to a post-LASIK ectasia if you're going to continue a surgery on these. This does give you what is known as the Corvus biomechanical index and the tomographic biomechanical index here. The tomography incorporated into the biomechanical assessment is the Corvus biomechanical index here, which helps you to pick up those subtle corneas which might be predisposed to post-LASIK ectasias here. So when we look at, we have the deformation amplitude, the applanation length, the corneal velocities, the arc lengths, the deformation ratios, and the inverse radius here. These are particular parameters which really help us to assess, and some of them increase and decrease depending upon the change, the biomechanical change induced by the laser refractive procedure adopted here. And this does give you a color-coded indication, and it helps you to understand how these are changing. Again, we do not have clear-cut values to say above this and below this it's going to be a clear-cut one of a weak cornea. But what we do have is the CBI, the BAD, and the TBI indices, which help us to understand if these are corneas which we have to red flag before we take up. Again, a word of caution, most of this data, this artificial intelligence, was based on the Caucasian eyes. It's still not a data which was extrapolated to Asian Indian eyes here. So I do take it with a pinch of salt. And when I do have a suspicious pickup on these, I correlate it with the topography pattern, look at the stability of the indices over two consecutive reports done 3 to 6 months apart, explain these to the patients, and before we take them onto a refractive procedure. So that's how I do adopt these, not on a hard and fast rule, but on a custom basis, on a case-to-case basis, to see how these indices apply to the particular cornea which we are taking up here. There are multiple studies which have come out here, and one particular which does talk about with greater applications to detections of subclinical keratoconus. I think more work is in this particular area in recent times, and probably we'll see more literature on this to help enhance our understanding here. But what you would really look at, and when you compare it in terms of control eyes and with keratoconic eyes, some of the factors which are most important is the stiffness parameters and the deformation amplitudes. When they are moving away from the normal ranges is when you're probably going to be looking at these being abnormal, and warning you that these are predisposed cornea, and you'll probably want to consider an alternative procedure for refractive correction in these. Again, I think due to lack of time, we'll not go into much of the literature, but literature currently is quite controversial in telling. Some do tell that there is a biomechanical change with the order being more in femtoflaps, smile, and then surface ablations. Again, surface ablations also induce biomechanical changes, though to a lesser extent. But then I think there is a fantastic study which has come out from India as well, where they have evaluated the biomechanical change intraoperatively and postoperatively during the follow-up, and have not found a significant difference between a femtoflap and a smile lenticule. So literature now currently is not giving us a clear-cut evidence on whether it is which one is better, or whether to say one causes more than the other, and some do say that they are equally effective in causing a biomechanical change. Yeah, but we all do understand when you're taking an ablation to higher levels, or a lenticule removals to higher levels, it definitely does cause a biomechanical weakening in the corneas which we are subjecting to laser refractive procedure here. So I think I will stop here in the interest of time, and thank you for your patient hearing here.
Thank you, Dr. VANATHI.